we have two resident talks today, one by myself. My name is Jamil, I'm one of the fifth-year residents, and I'll be discussing testosterone therapy and prostate cancer. After my talk, we'll have a discussion by Dr. Jay Amin discussing transperineal prostate biopsy, and this is the new gold standard. So I will begin with mine. All right, so I chose this topic because I think it's an important topic for a lot of urologic clinicians. Anyone treating patients with testosterone or anyone seeing prostate cancer patients, I think it's also an especially important topic for the residents as we become more senior, because in our VA clinic, we often see a lot of patients who have prostate cancer, and this issue of testosterone therapy and can you treat patients with testosterone who had prostate cancer, the issue comes up very frequently. And so I think it's important for all of us to know the data so that we can counsel our patients and potentially treat them. So the correlation between testosterone and prostate cancer is both complex and controversial. The initial recognition of this relationship was published by Huggins and Hodges in 1941. And on the right here, you can see a picture of Charles Huggins. He won the Nobel Prize in Medicine in 1966 for the work in androgen deprivation and metastatic prostate cancer. So this was the paper that was published in 1941. It was studies on prostatic cancer, and they looked at the effect of castration in men or replacement with estrogen on metastatic carcinoma of the prostate and serum phosphatases. What they demonstrated was that castration or treatment with estrogen in men with metastatic prostate cancer reduced prostatic acid phosphatase and tumor burden. And it was their conclusion that testosterone caused an enhanced rate of growth of prostate cancer. Since that time of the Huggins and Hodges paper, androgen deprivation has been the mainstay for treatment of advanced prostate cancer. When you fast forward to 1981, Fowler and Whitmore then published their series with the Memorial Sloan Kettering experiments for patients who underwent testosterone administration and metastatic prostate cancer. And in their cohort of 52 men who received testosterone, 45 had an unfavorable response, most within 30 days. So the study from Fowler and Whitmore and Huggins and Hodges ultimately led to that saying that offering testosterone to a man with prostate cancer was like pouring gasoline on a fire. So then in 2006, Abraham Morgentaler at Beth Israel Deaconess published a paper in European Urology, and that was entitled Testosterone and Prostate Cancer, a Historical Perspective on a Modern Myth. And he had been treating patients who were hypogonadal with testosterone, and he was worried about the impact it could have on developing prostate cancer. So he scrutinized the data of Huggins and Hodges a little bit more closely, and this is what he found. In the original paper, 3 men were reported to have received testosterone, yet the results were only provided for 2 of these men, and 1 of these 2 had already been castrated. The data provided information only on a single man who received testosterone administration without prior androgen deprivation. And in that single case, the acid phosphatase results were dramatic. When you looked at the study by Fowler and Whitmore of the 52 men, only 4 were not androgen deprived. And when you looked at those 4 patients, 1 had an early unfavorable result, and the other 3 continued to receive daily injections of testosterone without apparent negative effects. So if you scrutinize the data in that type of way, you can come up with a few different conclusions. So testosterone administration in men who were previously androgen deprived resulted in rapid and near universal growth in prostate cancer manifestations. However, testosterone administration in hormonally intact men produced little or no effect. And the findings suggested that there is a limit to the ability of androgens to stimulate prostate cancer growth. So the relationship of endogenous testosterone and development of prostate cancer. So in a man who has a high level of testosterone, does that man inherently have an increased risk of having prostate cancer? It's been extensively assessed. Most studies have shown no influence on endogenous serum testosterone in the ugonapple man or other androgens for prostate cancer risk. This was a study from the Journal of the National Cancer Institute, looking at 3,800 men with incidental prostate cancer and 6,400 controls. They looked at the relative risks of prostate cancer, and they found that the serum concentrations of sex hormones, including free testosterone, were not associated with the risk of prostate cancer. This was another study by the group at Bethesda Deaconess, and in this study, what they were doing was they wanted to see the association of the incidence of prostate cancer in patients who were hypogonadal. So in their study, which is highlighted in white, what they did was they took patients who were hypogonadal, who had a normal PSA, a normal digital rectal exams, and they did a biopsy, a trust biopsy. This paper was done in the 90s, and they looked at the incidence of prostate cancer in those hypogonadal men, but negative DRE, normal PSA. What they found was that actually in the hypogonadal men, in their series, the incidence of prostate cancer was about 14%, in line with the data from patients who had a positive digital rectal exam or a positive PSA. So there was something about hypogonadal men and the incidence of prostate cancer that almost seemed that those who were hypogonadal had a higher incidence. And in those men was PSA and DRE and adequate screening. So the question is, why does androgen deprivation therapy and stopping androgen deprivation therapy lead to all of these changes we see in prostate cancer growth if high levels of testosterone don't seem to impact prostate cancer risk? Well, that question is addressed with the saturation model. And the saturation model of prostate cancer and the androgen receptor demonstrates exquisite sensitivity to changes in androgens at very low concentrations, but little or none at higher concentrations. We know that the human prostate androgen receptor becomes saturated at around 120 to 200 nanograms per deciliter. And once the androgen receptor has been maximally bound, additional androgen doesn't influence the mechanism and serves merely as excess. And so this is a schematic of the molecular biology of this. So we know that the testicles produce testosterone. They go into their target cell, they're reduced by 5-alpha reductase, and then they become DHT. DHT binds as a ligand to the androgen receptor and goes into the nucleus. Our cells have a set limit of androgen receptors, and once those androgen receptors are fully saturated, the extra testosterone is not playing a role. So the saturation model explains why manipulating serum testosterone into or out of the castrate range produces arch changes in prostate cancer, whereas variations in serum testosterone within the naturally occurring range do not. Once the androgen receptor has been maximally bound, one should expect minimal or no additional prostatic effect from higher serum androgens. Therefore, the one group at increased risk of androgen-driven prostate cancer stimulation includes those men who have severely depressed testosterone below that saturation point. So testosterone therapy after prostate cancer diagnosis. Men who appear to be cured from prostate cancer after definitive therapy but are symptomatic for testosterone deficiency. What do we do in these instances, and is there anything we can do? So several studies have suggested that testosterone therapy may be used with caution in a very carefully selected population after prostate cancer has been successfully treated. So I just want to go into some of the data that has been published. So this is a study from the UC Irvine group that was published in BJUI last year, titled Testosterone Replacement Therapy Reduces Biochemical Recurrence After Radical Prostatectomy. And in this study, they looked at patients who received testosterone therapy after robot-assisted prostatectomy in about 150 patients, and they compared their results to patients who did not receive testosterone therapy. And just looking at some of the data here, you can see the vast majority of patients that they included had Gleason 3+3 or Gleason 3+4 disease. A few patients with Gleason 4+3 disease. There was no difference in the overall Gleason scores or pathologic stage. There was no difference in the preoperative PSA. And what they found in their study was that of the 150 patients on testosterone replacement versus the 419 controls, 7% in the testosterone replacement therapy group had a biochemical recurrence, whereas 12.6% of the patients in the control group had a biochemical response. The benefit was observed without an increase in the number of cardiovascular events, such as heart attack, DVT, stroke, for patients who received the testosterone therapy. And there was no suggestive rise in PSA to levels greater than 0.05 with testosterone therapy. And they were putting patients on testosterone therapy as soon as 3 months after their surgery. So the data in radiation, so in some reports we know that radiation can, in some reports, lead to lower testosterone levels after therapy, up to 20%, secondary to scatter of the radiation to the testicles. This is one study out of the Baylor group looking at testosterone replacement therapy after patients had undergone brachytherapy or external radiation, external beam. It was a small study, 13 hypogonadal men, defined as the presence of typical symptoms in total T less than 300 with prostate cancer. These patients were treated with brachy or EBRT and then testosterone replacement therapy, either with transdermal testosterone or testosterone pellets. And what they found after a median of 30 months, there was no significant change in PSA levels or evidence of prostate cancer recurrence, no risk of erythrocytosis, and that the replacement therapy improved hypogonadal men, the symptoms of hypogonadal men with subjective regards to energy, libido, and erection. For patients who are on active surveillance, there is a lot less data. There really is not that much data, and the data that we currently do have for patients on active surveillance really limited in the number of cohorts. There are a few small studies. This one from the group in Boston looked at a total of 28 patients who were on active surveillance who ultimately received testosterone therapy, and this is the largest study that I was able to find. So you have 28 patients on active surveillance. All of the patients had either Gleason 3+3 disease or Gleason 3+4 disease, and they compare them to a group of 96 patients who also had Gleason 3+3 or 3+4, but also a small percentage of Gleason 4+3. And there was no difference in the baseline PSAs in these groups. And when they looked at biopsy progression with follow-up of about 3 years, there was no difference, no statistically significant difference in the biopsy progression for this small cohort of men on active surveillance who were treated. There's also no difference in the increase in PSA over time, although it was potentially approaching significance, but it did not reach it. This is another study out of Canada. Again, another small cohort. There really isn't much data on active surveillance in patients on testosterone therapy. So this one had 8 patients on active surveillance with low volume Gleason 6 prostate cancer, and they were followed for a median of 27 months. There was no evidence of clinical pathologic progression. None had gone on to definitive treatment. 2 patients on active surveillance were taken off testosterone therapy due to early PSA rises. However, when you took away that testosterone, the PSA value returned to a similar level prior to their therapy. We do have AUA guidelines, and of course it's important for us to know the guidelines, and these are taken from the testosterone replacement therapy section. So we know that if you are going to start testosterone therapy in a man who's 40 years or older, you should measure a PSA prior to commencement of testosterone replacement. For patients who have an elevated PSA at baseline, you should confirm it with a second PSA to rule out spurious elevation. And if you do have suspicion for 2 elevated PSA levels, before you're going to start testosterone therapy, you should do a more formal evaluation with a prostate biopsy. You should also talk to patients about the absence of evidence linking testosterone therapy to the development of prostate cancer, as we've just talked about. Patients with testosterone deficiency and a history of prostate cancer should be informed that there is inadequate evidence to quantify the risk-benefit ratio of testosterone therapy. And prostate cancer patients on T therapy should have their PSA levels monitored at the same schedule as men without T deficiency. And recurrence in men on testosterone, PSA recurrence in men on testosterone therapy should be evaluated in the same fashion as untreated men. The EAU also has guidelines on testosterone therapy in the setting of prostate cancer. So they state that testosterone therapy is contraindicated in any locally advanced or metastatic prostate cancer. For men who are symptomatic hypogonadism, who have been surgically treated for localized prostate cancer, and who currently do not have evidence of active disease, can be cautiously considered for testosterone treatment. And these treatments should be restricted to those patients with a low risk for recurrent prostate cancer, so lower Gleason scores and pathologic stages, as well as lower preoperative PSA. And the European guidelines actually state that you should not start testosterone therapy before 1 year follow-up after surgery, and patients should be without a PSA recurrence. So just some conclusions to draw from all of this. There really is no compelling evidence linking high endogenous testosterone with the increased risk of prostate cancer. There's no evidence that treating hypogonadal men with testosterone leads to de novo prostate cancer. There's evidence to suggest that at low levels of testosterone, the androgen receptor becomes saturated, limiting the effects of further increases in testosterone. Raising testosterone in a patient with moderate but suboptimal T concentration is not the opposite of reducing T from normal values to almost zero. Before initiating testosterone therapy, warn patients of the limited safety data and explain that they are at risk for cancer recurrence whether or not they begin replacement. Men whose baseline testosterone is well below the saturation point have a substantial potential for androgenic stimulation, and that is a very high risk group for testosterone therapy. So men who have symptomatic hypogonadism, who have been treated for localized prostate cancer and don't have evidence of disease, can be cautiously considered for testosterone treatment. It would be a highly selected group, low-risk prostate cancer that would need close follow-up. There is no consensus on the timing of initiation. The European guidelines say you need to wait a year. However, there are, like we reviewed, there are some groups that are initiating treatment even within 3 months, so there's not a consensus. And that's all I have.
No, I have a question.
Yeah.
What do you make of that study from UC Irvine? They state, I think the title of their paper is that testosterone reduces risk of biochemical recurrence. Do you think that carries water?
I don't know that number actually reached significance in their paper, so it's a little bit misleading. Their hypothesis was that the patients who have lower testosterone have a worsened metabolic syndrome profile, that there's a lot of different risk factors for prostate cancer progression, and that those patients who have a lower testosterone may progress because of the increased risk of metabolic syndrome. But I think it was a little bit misleading.
Were they giving it to patients based on?
They were giving it based on if they were symptomatic, low energy, fatigue, low erections, and if they had a testosterone that was sort of borderline normal, so 300 was the average in that group of the testosterone in the low testosterone cohort, and they're checking testosterone actually routinely at 3 months at that institution, and they're getting testosterone preoperatively as well.
So I have a question from Dr. Moldavina, and it is PSA level on T a reliable marker? Is a correction needed similar to correction in men with 5-ARI?
Based on the data that I saw, there was no difference in patients who were on testosterone and the PSA levels while on testosterone levels. In the study by the Beth Israel Deaconess group, there was a trend towards seeing a 1 point higher level in the patients who were on testosterone therapy, but that did not reach significance. So in the data that I've looked at, there wasn't a difference in the testosterone, in the PSA levels for patients who were on testosterone. But I think it trends to a little bit higher.
It's a really good talk, Jamil, about a controversial and complex topic. That's well summarized. Abe Morgenthaler definitely has done the most work on this. I just learned he's retiring this year. But did you come across any data that he published about testosterone and the types of prostate cancer, levels of testosterone and types of prostate cancer?
I didn't see anything like that he published. He may have. He's got a lot of data on it, but I did not see data specific on various pathologies.
You published something when I was there with a co-resident of mine about how low testosterone was associated with higher grade prostate cancers in a cohort of patients that they studied.
Yes.
Again, it doesn't prove anything. It's a cohort study, but it certainly adds.
Okay, yeah, so I'm sorry, I confused your question. So I thought you meant in different types, like different histologic types. But yeah, there is definitely a lot of evidence that patients who have lower testosterone levels seem to have more aggressive types of adenocarcinomas of the prostate.
Yeah, which just adds fuel to the fire of this whole discussion.
So what's the hypothesis behind that?
I don't know.
So there's a few different, I think there's a few different lower testosterone levels potentially lead to the prostate cancer cell lines mutating so that they ultimately become an androgen independent type of cancer. And then there's this whole concept that prostate cancer is due to multiple things beyond just the androgen receptor itself, that patients who have low testosterone levels often have associated comorbidities like metabolic syndrome, and that potentially plays a role on prostate cancer growth and aggressiveness as well. So there's a few thoughts. I don't think that there is one definitive answer on that, but there are a few hypotheses on what drives that.
It's also hard to it's hard to evaluate that, right? Because if you look at the association between PSA level and aggressiveness of prostate cancer, there's clearly a relationship with higher PSA level. And so I think it's largely driven by there are these anecdotes where you do see people at very low PSAs, PSA 1 or 0.5, who have at least an 8 or at least 9. But the relationship is, I mean, clearly if you have a PSA of 30, it's worse than having a PSA of 1.
Yeah, he would say it wasn't anecdotal. They studied a cohort of patients, and again, it's not. It doesn't prove anything. It's just.
Are you guys able to hear me?
Yes, we can hear you.
Oh, great. I was trying to type, but that was getting difficult. Thanks, Jamil. It's a fantastic update. Just to address that question a little bit, Dr. Liebman. Yeah, I mean, these are pretty large studies, and Jamil already sort of mentioned it, but just to emphasize the point, I mean, if you have someone with a PSA of 4 who is hypogonadal, or if someone has a PSA of 4 who's on androgen deprivation therapy, that's very different than someone with a PSA of 4 who has a normal testosterone. And their pressures for mutation and aggressive disease have already occurred, and these prostate cancers have developed in that setting. That's sort of the leading thought, as he mentioned. So that's why I have no problem supplementing sort of anyone who's hypogonadal and even post-treatment, because I think that it unmasks their disease. Like, you can more clearly understand what their risk of recurrence is or what their aggressiveness of disease may be if they have a normal testosterone. If someone's hypogonadal, you're really just blinding yourself to what their aggressiveness of disease may be. And unless you want them to be on androgen deprivation therapy because they have metastatic disease, I think I agree with supplementation. I'm glad to see all the updates in the guidelines.
I think what Abe Morgenthaler would say is that once you have castrate-resistant prostate cancer, metastatic has 5 years to live, right? That's the average life expectancy. I think he would say that those cancer cells have already selected themselves out as resistant to the therapy and the aggressive cancer cells, that clonal selection. So I think he would say that the low testosterone environment selects out those. It's kind of shifting the curve to, that it's just pushing it to earlier selection of those bad cancers. That like I don't know if that's true, but I think that's what you would say is the theory.
Yeah, I don't know. I mean, of course, it makes sense that, right, if you sort of started the clock early, right, and because that's how androgen deprivation fails, right? These androgen insensitive clones proliferate. I honestly don't know how rigorous the evidence is that that's happening in patients with borderline low T. But makes sense. I mean,
Dr. Weiss asked, did you see any studies showing dose response curves of testosterone to prostate cancer cell growth?
So it's an interesting question. So I didn't look that deeply into it, but there is this concept of bipolar androgen deprivation therapy, so there was a study, a clinical trial out of Hopkins, where they were actually putting patients on metastatic prostate cancer on androgen deprivation therapy for a month, and then they were putting them on supraphysiologic levels of testosterone for a certain level of time, and then they were switching over, and they were finding good results actually when you did this bipolar androgen deprivation therapy. So I think there is some evidence to suggest that the level of testosterone would affect the PSA at some regard. I didn't look that deeply into it, but I think there is evidence to suggest that there is a change.
Good. So, Rajak, very good.
Today I'm going to be talking to you guys about transperineal prostate biopsy, and this is the new gold standard. We do not have any disclosures. So prostate biopsy. So prostate biopsy is something that's been around for a very long time. I did when I was looking up, the history behind it. Hugh Hampton Young, 1926, did the first technically prostate open cut down on the perineum and removed prostate tissue. Interestingly, in the progression of biopsy, the next was transperineal biopsy of the prostate, and later on changed to transrectal finger guided. And it wasn't really until 1974 that we had, 7 megahertz ultrasound probe that we could do transrectal ultrasound, and there was a shift now to be doing all transrectal ultrasound-based prostate biopsies. 1989 was the landmark paper by Hodge describing the sextant method, where you could identify prostate cancer outside of clinically suspicious lesions on DRE just in your systematic biopsies. Not intuitively, then there would be this belief that if we saturate and get more biopsies, we would be able to identify more diagnostic yield of cancer. That just led to more discomfort and pain, and described periprostatic infiltration and nerve blocks, and to the point now where we're kind of on this pendulum back, with controversies now about transperineal prostate biopsy. This is a paper by Filson. This is actually just talking about the incidence and pickup of MR fusion prostate biopsy. The reason I brought this up is, they mentioned even as recently as mid-2000s, 2010, 13, 15, it was less than 0.5% of prostate biopsies that were being done transperineally. And now we talk about it and we hear about it, but what's the actual number? It's probably less than 3%, but picking up traction, it sounds like, at least in the urology media. So this is essentially a bit of a table of talking points today. Is we're going to talk about the pros and cons of transperineal prostate biopsy. We're going to talk about cancer detection, infectious complications, regular surgical complications, antibiotic stewardship, the fact that you don't really have rectal bleeding with transperineal prostate biopsy, and most people aren't doing bowel preps. And then the cons, which would be, we use an ultrasound and probe, though for the most part with linear array probes, you really wouldn't need new equipment. And then, do we need the stepper and template guide biopsies? There's other techniques that we'll talk about, and then pain control, which is probably the main thing, that's been really affected. It's been really taken up. So when we look at complications after prostate biopsy, there really is not a significant amount of transperineal associated complications, more so than transrectal. There is an increased number of acute urinary retention. This is probably due to increased inflammation of the pelvic floor and surrounding effects on the rhabdo sphincter from nerve effects, passing the needle multiple times. But as you can see, there isn't really any rectal bleeding, and very low, if any, infectious complications, and as a result, very low hospital readmissions and the associated cost and burden associated with the sepsis event, prostate biopsy. If you look a little bit further at post-biopsy sepsis, up to 25% of men can harbor resistant flora at time of biopsy. This resistance we know is to be increasing, and rates of sepsis are increasing as well. Hospitalization rates, though low, like less than 1% or so, are increasing as well. This led to a AUA white paper in 2017 that discussed targeted prophylaxis with rectal swab, which is something that we do here, versus considering augmented prophylaxis. If you look at the cost of a post-biopsy sepsis episode, this can sometimes be on the verge of almost $20,000. So if there's roughly 2 million prostate biopsies being done in a year, each prostate biopsy has a risk associated, with almost $300 technically for an infectious event. Look at the AUA white paper. The targeted prophylaxis mentioned here is about fluoroquinolone resistance, looking at fluoroquinolone resistance, and if positive, then obtaining culture sensitivity. They also mentioned transperineal approach. I don't really go into it any further here. The issue with the antibiotic augmentation, one could think, is that if we're augmenting the existing practice of fluoroquinolone, then is that then defeating the purpose of antibiotic stewardship? Looking at targeted prophylaxis, there is a significant reduction in sepsis episodes, almost 4.6-fold reduction in sepsis events by checking fluoroquinolone resistance. However, if you look at who actually develops sepsis when these swabs are used, largely, these are patients who have fluoroquinolone resistance rectal flora. Fluoroquinolone resistant bacteria drives the risk of sepsis. So even though we are getting cultures, doing the swabs, we're putting them on different antibiotic culture documented therapy. The risk, is significant regardless, and that points to the fact that these pathogenic organisms likely have inherent virulent factors that make them more prone to infection, even if we do, the right thing. Targeted culture directed therapy. Papagiannopoulos and et al. Here concluded actually that maybe would there be a benefit to considering other avenues of getting a biopsy rather than transrectal. So if we look at transperineal specific infectious complications, this is a large cohort study, 1,400 consecutive cases from Australia. They were given a dose of ANSEF and they had 0 readmission for infectious complications. This large study from Canada, antibiotics were cefuroxime or Keflex. There were 3 empiric UTIs out of these 1,300 cases that were treated by a PCP. Only one of them was culture positive. Again, 0 admissions. This is a large US study. 60% received ANSEF, and then 40%, they later on changed their methodology, received no antibiotics for their biopsies. And it was 3 patients with LUTs and were empirically managed with antibiotics. No infections. This is a large cohort, the largest that we have is 3,000 cases from Italy. Fortunately, they did have a higher rate of UTIs, 2.4%, with a 0.7% readmission rate, and they were getting a fair amount of antibiotics. Now, the counter argument that has been raised in terms of complications is, well, there's an increased amount of acute urinary retention, and that leads to hospital admissions or at least representations. And usually that's all managed with, a Foley catheter and discharge, usually not a septic event. Looking at the same group of large studies, acute urinary retention rate was 1.8%, 1.6%, 0.1%, and then in that larger Italian study, 6.8%. However, if you further looked at all of their numbers based on prostate size and the number of cores that were taken, there was a direct correlation with the invasiveness of the procedure and the size of the prostate. So I think the key when we're talking about transperineal prostate biopsy is it has to have good cancer detection rate, right? We can't focus on simply the morbidity of the procedure. In this study, we looked at 240 patients that were randomized to transperineal versus transrectal, and there was no difference in the cancer detection rate. There was also no difference in their complication rates. In this large study as well, they did a 10-core transperineal prostate biopsy. The same group of patients also had ultrasound, so transrectal prostate biopsy, and they were able to pick up clinically significant prostate cancer, 30%, and 10% of these were exclusively anterior lesions. Okay. And in that large cohort study, they did a 10-sector template as well, and again, very high detection rates. So this is a really nice paper. They looked at heat maps for where prostate cancer is noted on MR fusion biopsies. And if we look at this, 39% of prostate cancers are actually in this anterior region. Now, they made this line of what is considered anterior of 16 millimeters above the base of the prostate. Of the periphery of the prostate, but that's a large number, and they compared that to the missed prostate cancers on transrectal ultrasound, and 80% of these were in the anterior mid gland. So that really points to this fact that, are we missing a large number of anterior gland disease? And is there a way that we could get this better? MR fusion helps us with that more so than transrectal ultrasound, and at least historically in the past finger guided. But this would be something that theoretically transperineal prostate biopsy would be very helpful at being able to capture an increase in our diagnostic yield. So I'm just going to start talking about the actual technical considerations of this technique. Transperineal, the transrectal. The biggest issue that affected being able to do this procedure when you compare a quick office transrectal ultrasound guided prostate biopsy is analgesia. It's theoretically, and without the right type of block, it's significantly more painful. So if we look at the anatomy, the main areas that require analgesia would be your prostate capsule. So this is your peripheral branches of the pelvic plexus, noted here on the yellow arrows. And then the pudendal nerve and the perineal nerve, which comes off and passes underneath the deep pelvic floor. So being able to target those nerve distributions to decrease the innervation and sensation of the pelvic floor is critical to being able to perform this and being able to perform it in the office setting. This is a really nice way of being able to block all three distributions in a single pass. This was published out of a very interesting study in China where they measured 2 centimeters lateral from midline above the superior horizontal plane of the anus and passed a needle to the start of the levator muscles, which is this green arrow, started injecting 1% plain lidocaine. The lidocaine infiltrates along the fascial plane of the muscle. The needle's advanced, ejected again. Now it is on the cephalad aspect of the levator muscle, and then you inject the remaining portion at the yellow line, which is prostatic capsule. They found this by actually doing a dissection on 5 cadavers on patients, preserving it in 10% formaldehyde, and then dissecting out the nerves. And they found that the perineal nerve runs 1.86 to 2.16 centimeters from that midline area right above the top of the anus. And they then tested this on the remainder of the patients in their study, over 30 more patients, and I'll show you the results next. The diagram on the right also shows the other locations of common blocks. The red triangle is the periapical triangle, which is the medial aspect of the levator ani muscles to the apex of the prostate. And then that blue circle right at the corner is where your normal periprostatic nerve block is performed. So if we look at how long does this nerve block actually take, it does take a little bit longer. It's 4 minutes versus your normal periprostatic nerve block, maybe 2 minutes, which is a significant difference. But the overall procedure time for them was 14 minutes. And if you look at their visual anesthesia scale, which is a 10-point scale, where 10 is significant, most severe discomfort, 0 is no discomfort. Doing that perineal nerve block has a score of 1.8 versus 3.3 for a standard periprostatic nerve block, which you do for a truss biopsy. These are several other studies looking at the other more classic forms of nerve block, the pudendal nerve block, periprostatic, periapical triangle, and then skin subcutaneous analgesia, infiltration, and all of these score numbers you can see on that VAS score are around 3 or below. And just as a baseline for comparison, just inserting the transrectal ultrasound probe on average is considered a 2.4. So moving on to how do we actually perform this, right? So originally we had the stepper, the grid, that required us to insert needles using the grid template that we use for cryo and other procedures. This requires a significant amount of analgesia to anesthetize that area of skin, and also multiple passes. There's been development of new forms of attachments to ultrasound probes, like this precision point device that can be inserted into the skin and used to direct the needle then into the various areas of the prostate in a sagittal plane, and using a freehand technique. So just to explain that template method challenges in general, using the grid, it's 8 centimeter by 8 centimeters, 64 square centimeter area of skin that needs to be anesthetized, compared to the freehand fan technique where you just have to anesthetize 2 areas. Another issue would be if the prostate is large, usually over 100 cubic centimeters, you'll have difficulty then reaching the anterior areas, at least the anterolateral aspects of the prostate, given the pubic rami. So that is in itself a difficulty and lends merit towards the freehand technique, which is why it's coming into favor, even though a little bit technically more challenging. So what sort of biopsy template should we use? And there's many that are out and published. There really isn't significant or any real data right now that favors one over the others by far. The one that I had mentioned before, just to show the diagram, is the 10-sector biopsy template. The idea is to focus the biopsies in the periphery of the prostate, that peripheral zone where most of prostate cancer exists. This is done in the mid-gland, and then additional biopsies are obtained at the base at the lateral horns to increase the yield. If you look at where these cancers are distributed amongst these different sectors, it's actually all of them. So that just lends merit to the fact that getting good and spread out coverage amongst the periphery of the prostate will increase that diagnostic yield and make sure you're capturing the disease. So what about MRI fusion? So MRI fusion is possible. However, it's primarily done cognitively at this time. This is one of the largest studies I could find. It's 400 patients. They did 12 core systematic and then two target cores for each lesion that was PIRADS 3 or above. Overall detection rate 65%, and as you can see, they were able to capture those more aggressive, more dangerous diseases at a much higher rate as you would expect. Technically, this is challenging. You have to be able to identify those lesions and then get them in a freehand technique. So using the device at that precision point is very helpful because at least it isolates one plane, because your needle insertion and your transrectal probe are all within one plane, rather than having 3 planes. What about software-assisted fusion? So for freehand, the most common devices, the Euronav, the PK, Coelis, the MyLab, they all allow for it through software features. These are challenging to use simply because you have to establish your own landmarks on the MRI, and you have to perform frequent fusion readjustments because the patient is moving, and there's no sampling trace memory. So it's not great for active surveillance because you can't have the identical same biopsy taken the next time, which you can transrectally with the other methods. Template, there's the biopsy, but again, that you lose the benefit of the freehand, right? So if you have a large gland or you have a narrow pelvis, then you can run into the pubic bone. And this one also requires anesthesia to use. That's what they recommend, or spinal, if not general. So that's an issue there. And then for Artemis, IgAN, which we have here, you have the same issues in template being, it's a fixed robotic arm. So if you have, again, narrow pelvis, big gland, you could theoretically run into the bone. So you also should be pretty facile with the freehand technique. The benefit of this is you can do this in the office, and it's published by Zeng et al. Cornell, where they did this on 33 patients, 9% of which they weren't able to perform using the device because they were obstructed by the pubic bone. So just in conclusions, transperineal prostate biopsy, it greatly reduces the risk of infection by avoiding rectal and transrectal needle advancement, but also prevents rectal bleeding and analgesia risks. There's no need for antibiotic therapy. There's many studies that have shown this to this point, and a lot of institutions and urologists are doing this without giving any antibiotic therapy. We have new methods now from analgesia perspective to perform this under local in the outpatient setting, which should be helpful to picking this up, where this was previously considered to be done under general in the OR setting. And there's excellent cancer detection rates compared to transrectal, and possibly even superior with respect to the anterior lesions. So this is a picture of John Maynard Keynes, a British economist, who said there lies difficulty not so much in developing new ideas, escaping from old ones. I think there's been a lot of topic now at SUO this past week about transperineal prostate biopsy. I'm interested to see if this is something that's going to be picking up to some more extent and become the standard moving forwards.
Where do we stand at Yale? Are we starting to look into doing this?
I think so. As far as I know, we're not doing this to this point, but I think it's something of interest. Some people have thought about this. We have reduced the infection rates pretty significantly from doing the fluoroquinolone swabs, but again, no, we're not doing this. As far as I know.
Yeah, we're not currently doing any transperineal biopsies. Anyone who needs or requires a transperineal biopsy will have an in-bore in MRI bore transperineal biopsy done by Dr. Ayagari. Jay brings up a lot of interesting points. I'd love to hear Dr. Lietman's thoughts on it as well. I think the conclusions, I know you didn't, Jay, but I was going to say, how much is Precision Point paying you? Because these are their talking points directly. You know, the risk of infection definitely is decreased. The need for antibiotic therapy, I agree, it is decreased, but many providers still are administering antibiotics. So it's not really helping with antibiotic stewardship. And really need to sort of drop all the antibiotics if we're going to fully go that way. Because currently, as you mentioned, our infection rate is very, very low and comparable to that of a transperineal approach. So I think we can't use that as the sole argument. But we're looking into it. It will depend on, it sort of depends on our hardware, right? We're very married right now to Artemis as our fusion platform. And we may or may not be able to, we may be transitioning from that, which would allow us to add transperineal approach to our biopsy. One of the major challenges is there is a disposable cost. Those precision points or whatever you want to use to get access to the perineum can be costly. Although if we offset that by removing our rectal swabs, that opens up a lot of nurse time and would potentially make it a pretty even on the balance. I haven't looked at the numbers.
We actually did a lot of these at Bellevue because a lot of patients refused in-office transrectal biopsy, and once we were doing it in the OR, we purposely booked it as transperineal to practice the technique. There's a short, I can text someone to find out the specific one if people are interested. There's a short 14 gauge metal needle with an outer cannula that we used instead of the Transperinealogic. It worked just as well, but it's like a lot cheaper. And it's the same thing. We block the skin, stick it in, take it out, and then it's completely freehand. It's independent of the ultrasound, so it's a little bit more difficult than the one that's mounted to the probe. But I mean, it's just like it's a widely available disposable that the hospital buys for, I forgot which service. So it's significantly cheaper, and it serves mostly the same thing.
Not sure if you touched on this, but what is there anything that shows like an actual learning curve? Like how many cases of these do you have to do to feel comfortable compared to rectal?
Yeah, so I actually came across two different studies. One of them was actually just 10, but then another one said around, it was like 80. So to be honest, I think it varies a bit, and I think it depends. You know, I could imagine it being very challenging initially with freehand. The other thing to consider as well, which is less of an issue, you know, if you're even doing freehand transrectal, is the distance to the prostate where you're entering the needle, right? You have to pass through skin, subacute fat, you have to go through the pelvic floor, you have to go through the levator ani and then the prostatic capsule. So by the time your needle gets there, if you don't have any ability to direct it once you pass a certain number of layers, they've actually measured how far these needles can deviate sometimes compared to an ROI, and it can be up to 9 millimeters. And given that these ROIs are sometimes captured at sizes of like 1.3 millimeters, you know, you can miss it.
That's why we use that's why we use Fusion software. So I mean, it tracks the needle location and the ROI. So cognitive, it's very, very difficult, and I think it would be hard to do. I mean, this is a great evolving area of interest and research. I mean, part of it is how many biopsies do we need to do? Because in a large prostate, you showed the 10 sector, so that's 20 biopsies. So that's already more than we do with a standard template, but that's probably appropriate. In a large prostate, you aren't going to be able to get a 2-centimeter throw. It's not going to cover the entire length of the prostate. So you're going to need to do apical and base. So you're looking at potentially 40 biopsies just to do a basic sampling. So I think we have to decide how much you really need there, and can we just do targeted biopsies and then a limited sampling? So there's a lot of interesting areas here.
Do you think patients, when they all this talk about not doing it transrectally, do you think the patients understand that they're still getting a transrectal ultrasound?
You know, I think,
Because it seems like that's still transrectal.
yeah, I think, you know, that's that's probably their concern, right? Like that would be what they're concerned about. I think we focus so much on the infection aspect that we really don't think about maybe what the patient's actually more concerned about. I think, kind of, from a quality perspective, it's still the same, right? But maybe you have less, rectal discomfort, risk of hematoma, and so post-operatively maybe it's a little bit better, but yeah.
So there's certainly a marketing component to this, right? Where it's like, why have it done transrectally? We'll do it transperineally. And then, oh, by the way, we still have to put this probe in transrectally. Seems maybe that's, I wonder if patients really understand that.
They don't. It's full marketing. I mean, the perineologic guys are full bore in marketing, and people are asking for this without having any idea. I have many people that come to me asking for it, and they have no idea what it actually means.
Yeah, one of your cons was for transperineal was there's higher urinary retention efforts.
Yes.
And I would think that when you're doing a transperineal approach, you're going to be basically high risk of manipulating or kind of irritating the vulvar urethra and maybe injuring the urethra. I think I would be very concerned about that. I mean, I imagine you're tracking right along the urethra for a longer course, trying to do each biopsy, probably lighting more attention.
Yeah, I think a lot of them. That's I think why most times they're trying to avoid the transitions on the central areas of the prostate. But for sure, I mean, you pass at times pretty close to the sphincter, and so I think a lot of it has to do with passing the needle multiple times to the pelvic floor.
And in clinical practice, Dan, talking with some colleagues who do a lot of these, they do not find a significant increased risk. The increased risk was really reported in people doing saturation template biopsies, and often that was with anesthesia. So there's the complications, multiple factors of having 30 to 60 samples taken through a transperineal template. So like multiple punctures through the pelvic floor, and most of those guys were also getting anesthesia. So in the local anesthesia, freehand, in the office, fewer biopsy cores, it seems that the rate of, it's higher than with a truss biopsy, but not significantly.
Jay, a quick question. There's a guy named Lynn Hammers in the community who does transperineal prostate biopsies without doing a transrectal ultrasound. He usually does it in folks who have a history of APRs and an absent rectum. Have you seen any studies where they've done that kind of ultrasound guidance where they're actually not doing a transrectal approach and doing the perineal biopsies?
I haven't seen that published, but it sounds like prostate biopsies that were done before the advent of transrectal ultrasound probes. Maybe it's like, I don't know, type of abdominal ultrasound and hopefully passes through visually.
I would recommend that anyone thinking about that, send them to Raj for an MR guided, because then you also get targeted biopsy of the lesion if there is one, rather than doing a transabdominal transperineal approach.